thank you to be back in this room because there is a party in the other room. So I was afraid that no one would have been back. Instead, thank you to be here. Okay, the last block of this seminar will be dedicated on the mother of every disease, which is the inflammation. This morning we start speaking about the father of all the therapies, the drainage, and now we will approach the problem of inflammation. And honestly, in my experience, combining good drainage and good anti-inflammatory therapy, we will have a big part of all the tools of low-dose medicine. But, as always, start from the pathophysiology to arrive to the protocols in different type of inflammatory diseases. We have stressed the concept that every disease is a systemic disease, and we already spoke about the axis in our body. The biggest axis, which is the PNEI axis. Then this morning I spoke about the GBA axis, and to introduce the inflammation, I need to speak about the HPA axis. That is the stress axis. Please raise the hand, the one in this room who is not stressed. God save you. You are the only one not stressed. Good, you have a good approach to life.
I take an adaptogen, that's why
okay, good. Anyway, 1 in 25 people. So this is a universal problem. Stress travel along this axis, which is HPA axis, which is involved also in inflammation and in general in the alteration of the immune system. Hypothalamus, pituitary gland, adrenals. Let me see if I have, okay. It's interesting, excuse me, okay. It's interesting to see what happens when we activate these axes. Always think in terms of psychoneuroendocrine immunology. So, sorry for my scheme, this is a brain, okay? This is a mesencephalic structure. This is, for instance, a psychological stress. Everything is communication, so the cortical part communicate to mesencephalon, mesencephalon to hypothalamus. Hypothalamus, in this big chart of the stress, responds releasing hormones, hypothalamic releasing hormones, that stimulate pituitary gland to produce hypophyseal tropins, especially under stress, ACTH. ACTH stimulate adrenals to produce, you know very well, cortisol. Cortisol is very involved in stress. But cortisol, as well as every other signaling molecules, cytokines, neuropeptides, is neither good nor bad. It depends by the concentration. Because if I have, like our friend, your name is? Fabrizio. Is Italian origin. That's the reason why it's not stress. Okay. If we are like Fabrizio, we have cortisol in an homeostatic concentration. And in this concentration, cortisol is absolutely good. We need cortisol. For instance, we need this level of cortisol around 8-9 a.m., the spike of cortisol, to approach the stress of common life. But if we are under stress, I mean continuous stress, we have cortisol upregulated. I mean, instead of to be here, we have cortisol here, 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 plus, plus, plus. That's a killer of our body through inflammatory processes. And what is interesting is that if you relate cortisol level to PNEI, cortisol is able both to interfere with the higher part of the PNEI axis, nervous central system, and immune system, even though it starts from the endocrine system. There is a continuous communication. For instance, look which are the consequences of hypercortisolemia on the central nervous system. I bring you back to the desk of university. Hypercortisolemia through the so-called long circuit of negative retroaction is able to downregulate CRH. I mean, that's the real reason of burnout syndrome. When we are under hypercortisolemia due to chronic stress, cortisol burns the receptors at the level of hypothalamus. So you can see which is the interference of cortisol with the highest part of the PNEI. Interesting. Second, please look at this slide, and the second one will be even, the following one even most important. So, HPA hyperactivation, higher part of the PNEI axis, ACTH and cortisol go up, 5-hydroxytryptophan goes down. Now we understand which are the relationship between stress and depression. If cortisol downregulates 5-hydroxytryptophan, which is precursor of serotonin, now I understand. And now look at this slide. That is really the following one. So interesting, and will be very interesting to understand what to do with your patients with depression and with fibromyalgia. And I will open a chapter on fibromyalgia. Don't be scared. It's easier than it looks like. Okay, follow my pointer. HPA activation, left part of the slide. Hypercortisolemia. Hypercortisolemia inhibits neurotrophic factors. Do you remember NGF, which raises up when you are in love? To be in love is exactly the opposite to be stressed. Now that I'm married, I know, but I was very stressed. No more now. Now I am like Fabrizio. She is my downregulation of cortisol. Okay. Neurotrophic factors downregulated, you don't have a good neuronal repair. Apoptosis of neurons. Now we know which is the relationship between stress and neurodegenerative diseases, including dementia or Alzheimer's. Everybody knew that. The hormonal pathway of dementia. But even more interesting is that part, the right part. Under stress, we start with low-grade inflammatory processes. Which is the link between chronic depression and dementia? Is the inflammation. In fact, low-grade inflammation, look that all of you, even Fabrizio, is chronically inflamed. Absolutely, we are under attack of chronic inflammation in this world. Low-grade chronic inflammation, among all the things it provokes, activate two enzymes. One is called 2,3-indolamine deoxygenases, IDO. The other, tryptophan deoxygenases. But especially important is IDO. Why? IDO is a bastard enzyme able to shift the physiological metabolism of tryptophan in 5-hydroxytryptophan, tryptamine, serotonin, in the pathway of kynurenine. What kynurenine is a fake serotonin. But being fake, it is able to bind the receptors for serotonin, occupying those receptors and not allowing the right serotonin to bind the receptors. Now we are connecting depression with inflammation with stress. look, that is really interesting. Not only because the kynurenine pathway has also the problem that kynurenine is a very neurotoxic substance. So, especially at the level of hippocampus, is able to provoke hippocampal atrophy and hippocampal, the site of remembering, Alzheimer's, dementia. What I'm telling you, depression is an inflammatory disease. Dementia, Alzheimer's are inflammatory diseases. If you don't act on that passage, you can use specific selective inhibitors of serotonin, but you will be not curing the depression. Act on the inflammatory part. What is interesting, that we know which is the marker of this low-grade chronic inflammation. Is an interleukin. And in this hour and a half we will stay together, I will stress a lot on this part. This low-grade inflammation is due to interleukin-6 upregulation. That you will die because of that guy, Because until 50, your interleukin-6 is very low. After 60, 50, boom, it starts increasing. The problem is that if you don't have any focus of low-grade chronic inflammation, you will die at 120 years. But if I look inside of your gut, it will be inflamed. If I look at your joint, they are inflamed. Apart Fabrizio, if I look inside of your brain, you are inflamed. So you have continuous triggers of chronic inflammation. That means interleukin-6 is higher than physiologically. That's the reason why we will die before, but I don't want to die. So I am under treatment to counteract interleukin-6 because I have a lot of things to do. Okay, you too. So we have to do a lot. So it's important to take under control that guy. You will see, and I will explain why, that we have the possibility to block interleukin-6 according to Mother Nature, which is the interleukin that normally takes under control interleukin-6 is another one, interleukin-10. And we are the only pharmaceutical company in this moment producing interleukin-10 in form of drops. So really, it is very important. I'm convinced that in the next 5 years, Guna interleukin-10 will be the best-seller medication in terms of anti-inflammatory medication in the world. I'm really convinced about that, or at least this is my dream. So, interleukin-6. This is, it's not an index paper, it is a journal. I'm sorry, it's in Italian, but in 2014 they spoke in terms of depression, psychiatric disease or inflammatory process linked to stress, and they say subjects with high level of stress have high level of interleukin-6. Who are those guys saying that? Mount Sinai School of Medicine in New York. So they are saying depression is an inflammatory disease. If you have patients under treatment with antidepressant, please give them even interleukin-10 because you will block one of the triggers. Interleukin-6 is responsible of many problems, and especially of these three aspects: depression, pain, fatigue. All these three pathways are due to interleukin 6. Please, can you tell me one disease which presents in the same time depression, pain, fatigue? Fibromyalgia is the first. Cancer, very often. So when you have these three aspects, always think of interleukin 6. We focus our attention, and we have an ongoing study on that, on fibromyalgia. Until 10 years ago, you remember, fibromyalgia was not considered a disease. And women, because the most part of patients are women, were considered hysteric. In fact, some of the medication used for fibromyalgia were antidepressant. Poor women, they were not hysteric or depressant. They were inflamed. I have to thank Professor Riccardo Torta, neuroscientist at the University of Turin, for this slide. With some technique of brain mapping, they take a picture of the brain of fibromyalgia patients. And always they found in the same area of the brain, area of inflammation, exactly perivasal inflammation, due to an overexpression of interleukin 6 and, in that specific case, also VEGF, vasal endothelial growth factor, that is involved in neoangiogenesis, good neoangiogenesis, if you express VEGF in an homeostatic concentration. But if you produce too much of VEGF, it has a pro-inflammatory activity 1,000 times stronger than histamine. This VEGF is also overexpressed in autistic children. Also, autism has some aspects of inflammation. Interesting is that because of this brain area inflammation, the patient feels pain. It's not an idea of pain. He has pain. Where? In the trigger points. You know that we have 18 trigger points, and to be diagnosed for fibromyalgia, we have to be positive at least to 9 of the 18 trigger points. I will show you which are these trigger points. And the diagnosis is quite easy also. So, if you do a pressure of 2.4 kilograms per square centimeter in a trigger points of a fibromyalgia patient, you provoke pain. To provoke pain in a healthy person, in the same trigger points, you have to put a pressure that is 4.16 kilograms per square centimeter. What does it mean? That the more sensitivity is due to this inflammation, and this inflammation is due to interleukin 6 and VEGF overexpressed. So now we are performing a clinical trial, giving the patients 20 drops twice a day for 3 months consecutively of Guna interleukin 10. Guna interleukin 10. Because the problem of fibromyalgia is she is inflamed. The clinical trial is performed only with Guna interleukin 10. But I want, this is okay, what I want to ask you, trigger points in which tissue are? Muscles. Do we have in the muscles the extracellular matrix? Absolutely yes. So, will be important to combine Guna interleukin 10 plus Guna matrix. My friend, please, absolutely yes. Also because when you, with the digital palpation, do you say palpation? Palpation. Okay. you palpate, you feel like a note there. How to solubilize that extracellular matrix? Guna matrix, absolutely interesting. In the protocol, we also consider other two possible medications to be used. One is Gunaflem. Gunaflem is our general anti-inflammatory medication. I will show you the composition. When do we use? We use at the need because it contains beta-endorphin. So, through beta-endorphin, we can manage the flare of pain that sometimes during the treatment the patient can have. Beta-endorphin is a very interesting opioid substance because it's able both to work on the peripheral and central pathways of pain. You remember, peripheral part because beta-endorphin reduces the release of P substance. Central part because beta-endorphin downregulate GABA, increasing dopamine. If you increase dopamine, you are more motivated, so you feel less pain. That's the double mechanism, peripheral and central of beta-endorphin. It is contained in Gunaflem. So, for 3 months, matrix and interleukin 10. When the patient for that day has pain, Gunaflem, 10 drops every 30 minutes for 2-3 hours until acute symptoms disappear. Very often, as you know very well, these women have sleep disorders. We don't know if they have sleep disorders because of the pain or they have the pain because of the sleep disorders. So, if there is sleep disorder symptomatology, our medication is Guna Sleep. It's interesting because beside some typical homeopathic remedies like Ignatia, Valeriana, Melissa, we have melatonin and serotonin. So you manage also that depressive part of these patients. Interesting. Normally we use 20 drops twice a day, and in terms of hypno-inducing activity, other 20 drops 30 minutes before to go to the bed. Okay, these are the 18 trigger points. Okay? Normally, to be diagnosed with fibromyalgia, at least 9 of these ones have to be positive. It's easy because you have to exert a pressure until your fingernail become white. Which is the pressure? You exert this pressure. When your fingernail become white, if your patient scream, it is positive. If doesn't scream, negative. If 9 of the 18 trigger points will be positive, it means in your office for 9 times someone screaming. With that pressure, in terms of palpation, it is positive. This is so. Is the fibromyalgia a systemic disease? Oh yes. That's the reason why we are thinking of interleukin 10 and matrix. But I want also to introduce you in a very brief way to the possibility to use some injectables. We have a line of injectables named Guna Medical Devices. They are in vials and they are collagen based. Together with collagen, which is type 1 collagen, we have in every different medical device some auxiliary substances, mainly arnica, viola odorata, these homeopathic remedies. The main component, but really just 10 minutes, the main component is collagen. Why collagen? Because look at this slide. These are collagen fibers in a healthy tendon. You can observe that all the collagen fibers are parallel each other. That's the picture of a healthy tendon or ligament. B, C, and D are other tendons affected by injuries. You can see that more severe is the disease, more destroyed is the alignment of the collagen fibers. Look at this picture. These are the so-called moth-eaten, typical in muscles of fibromyalgia patients. I mean, in fibromyalgia patients, this alignment of collagen fibers, in this case they were tendons, or in muscles, is completely destroyed. This is another picture with anatomical pathology report. Look at the collagen fibers, moth-eaten, it's not good, and normal pathology report. So, in fibromyalgia, we need to feed those collagen fibers. We need to recover the parallelism, the alignment of the collagen fibers. Why this alignment is so important? Okay? Oh my God, I want to go straight. Because, have you ever heard about anisotropy or tensegrity? Tensegrity, okay, you say tensegrity, okay, good. This is a specific and particular capability of some structures, including collagen fibers, to exert only in one direction a tensile strength. For instance, when I exert a tensile strength at this level, my gastrocnemius, the tendon, the Achilles tendon, is strength in one direction only. Why it is so important? Why Mother Nature did that? Because if you have a good tensegrity, you are able to strengthen the fibroblast only in one direction. Why now I'm speaking about the fibroblast? Which is the cell which produce your collagen fibers? The fibroblast. Where do you have the fibroblast? Unfortunately, little number in tendons, in the extracellular matrix in general. If you are able to strengthen the fibroblast only in one direction, the fibroblast respond producing collagen. To have this capability to strengthen the fibroblast only in one direction, you need to have all the collagen fibers drawn in the extracellular matrix parallel each other. Unfortunately, due to low-grade chronic inflammation, due to injuries, due to aging, you lose this parallelism of the collagen fibers. So, day after day, you are unable to produce the right quantity of collagen because losing the tensegrity, you don't strengthen the fibroblast only in one direction, you don't produce more collagen, and your tissue will degenerate more and more. So, why to use the collagen-based Guna medical devices? Because injecting in the extracellular matrix, that is with the little needle superficially in the skin of your patient, collagen, you recover the parallelism of the collagen fibers. It means that you increase the tensegrity, it means that the fibroblast will be strengthened in one direction and it will produce more collagen, more enzymes. In this way, you recover a good histology of the extracellular matrix. Okay, we have a range of products which are 13. For those of you who are involved in orthopedics or rehabilitative medicine, 9 of them are specific for specific areas of the body. 5 are aspecific for the areas, but specific for the origin and the type of pain. MD muscle, if the pain is due to a contraction in the muscle. MD neural, if the origin is neurogenic. MD poly, if there is a polyarthritis. In fibromyalgia, we use the combination of 2 MDs, which are MD muscle and MD neural. Okay? 1 ampule of MD muscle plus 1 ampule of MD neural in the same syringe, injecting 0.5 milliliters in each trigger points. So you have, through the ampules, a direct activity on the trigger points, and through Guna interleukin 10 and Guna matrix, a systemic management of the fibromyalgia. But if you have other musculoskeletal disorders, you can think of the specific MD. For instance, and I want to show you the clinical trial we performed. Oh. We performed with the MD knee injected intraarticularly in knee osteoarthritis. It is a comparative clinical trial with hyaluronic acid that you know is the gold standard treatment for osteoarthritis. Has been published on BMC musculoskeletal disorders, performed by the Institute of Rheumatology of the University of Rome. Inclusion criteria: all the patients had to be diagnosed as with osteoarthritis according to the American Rheumatism Association. All of them more than 40 years. This is important. Radiological degree, second 3 according to the Kellgren-Lawrence scale. Just to have an idea, this radiological picture. When you have a 4th grade, according to Kellgren-Lawrence, you need the prosthesis. Okay? These are the 80% of the patients, if you are, some of you are general practitioner, normally you see. Disease activity according to the visual analogic scale, over 4 centimeters in terms of pain at T0, and disease activity assessed by the Lequesne knee was very high, so they were unable to walk well. Okay, these are the results. I don't want to waste time. They have been treated for 5 weeks with 4 milliliters of MD knee, just to show you the effectiveness, one group. The other group with the gold standard treatment, that is hyaluronic acid intraarticularly, 2.5 milliliters once a week, the same for 5 weeks. Follow up at 3 months and 6 months. Lequesne index, that is algo functional index. Red line is MD Guna, blue line the hyaluronic acid. In terms of absolute terms is more effective the Guna product, but being the standard deviation very high, we can say they are the same. The same results also in terms of pain and in terms of quality of life questionnaire. The last data I want to show you, since with the previous data we understood that MDNE and hyaluronic acid work in the same way, is the consumption of painkiller acetaminophen. The group treated with MDNE needed less acetaminophen for the control of pain in terms of painkiller therapy. This is very important because if they had to use less painkiller, it means that they were treated better with the MDs. This is something new in your country because I think that you introduced the injectable MDs in the last months. Try to use MD muscle and MD neural in your patient with fibromyalgia. Or I think you have also the brochure on MDs. Okay, you have in the brochure is perfectly described everything about these products. Since our topic now was the fibromyalgia, once again, the association of the two ampules to be injected is muscle and neural. Okay, good. And what does the cortisol do on the lower part of the PNEI axis? Now we have seen how hypercortisolemia can affect, oh my God, can affect the higher part of the PNEI axis, provoking depression, provoking dementia, Alzheimer's, and so on. But cortisol, hypercortisolemia, is able also to alterate the function of the immune system, provoking immune depression. Yeah?
Sorry, just a quick question. Can you actually test for levels of IL-6 or
yes.
in your blood?
Yeah, you can easily. The lab tests all the cytokines and also the TH subsets.
Okay.
So if you have some doubts, you can ask for the dosage. Otherwise, if clinically you diagnosed for fibromyalgia or depression or other diseases, for sure interleukin-6 will be high. Anyway, it's easy to test.
There's a lady who isn't here today, and they have her details, Linda O'Connor.
And she does the testing for it, does she? Okay. And also, is there any side effects for administering IL-10 to people?
Absolutely not.
No.
100% of safety at that dosage.
Okay.
And we have seen that in all our clinical trials. No problem, even for long time. You don't have any side effects, even if you administer for a long time. You don't have any interference with other treatments. I mean, sometimes your patient is under corticosteroids. You cannot suddenly avoid the corticosteroids. So my suggestion is always that one of overlapping. Your patient stays under corticosteroids, you enter with interleukin-10, you decrease corticosteroids until you avoid the corticosteroids. So absolutely 100% of clinical safety. What does it happen under stress on the immune system? It happens something that is not nice, because we have, due to hypercortisolemia, a downregulation of TH1 subset. Before going on this slide, I want to share with you something that I share everywhere in the world to explain the immune system function. That is not something easy. So, how can we do to understand how our immune system works in a very easy way? Follow me at the flip chart. So this is a premise that is so important. In our immune system, we have hundreds of different cells. Especially, we have two big families of immune cells called CD4 plus and CD8 plus. Focus your attention on CD4 plus cells. From CD4 cells, we differentiate Th1, you are already familiar after this day, Th2, Treg. Actually, we differentiate many others, but in this moment, this is important. Th1, they are responsible of cell-mediated immune response. That is the acquired immune response, the first front of defense. Th2, they are involved in the humoral immune response, adaptive immune response. Treg, they are responsible of immune tolerance. I mean, these guys are those ones able to take under control both Th1 and Th2. And why Th1 and Th2 have to be under control? Because concept of homeostasis. If Th1 are expressed in the right number, homeostasis, they drive the cell-mediated immune response. But if they are overexpressed, they are the main responsible of inflammatory processes. Th2, they are responsible of the humoral immune response if in homeostasis. Upregulated, they are responsible of allergies. Treg, they are responsible of the good immune tolerance, thanks God, if they are here. If they are overexpressed, they are responsible of immune deficiency. Because being working too much, they downregulate both Th1 and Th2, inducing an immune depression. This is the picture you observe in your cancer patients. By an immunological point of view, cancer patients have an overexpression of Treg and a secondary underexpression of Th1 and Th2. If they don't have a good Th1 and Th2 activity, cancer cells make a party. From CD8, we differentiate T cytotoxic cell and T suppressor cells. They are super important because, for instance, they are involved in the immune surveillance against cancer cells. All these cells are related to each other. Everyone talk to each other. So, coming back to our slide, hypercortisolemia downregulates Th1. It is a big problem because if you downregulate Th1, you don't have more a good immune competence. Do you observe in your patient under stress and higher viral infection susceptibility? Oh yes. Typical is stress and labial herpes. Why? Because cortisol so high downregulate Th1. Th1, do you remember, they produce gamma interferon. Is gamma interferon involved again in the defense against viruses? My God, yes. But not only, crosstalk. Gamma interferon produced by Th1 is the word able to tell CD8+, hey, please guys, produce Th1 cytotoxic cells. These cytotoxic cells are the cells able to kill a cell infected by a virus. But from CD8+, we also differentiate T suppressors. T suppressors are those cells that as soon as they see a cancer cell, they kill it. So if you are under stress, you don't have a good Th1 activity, you don't produce gamma interferon, you don't stimulate CD8+, you don't produce T suppressor, and the cancer go on. Is it important to use gamma interferon in cancer patient? Oh yes. Is it important to stimulate Th1 with interleukin 12 in cancer patient? Oh yes. You understand how our immune system works, no? And how stress through cortisol can alterate this function. Okay, you already know this. Even if local, so is it clear Th1, Th2? Which are the lymphocytes involved in inflammation? Th1 or Th2? Th1. Focus on Th1. Upregulated, it means inflammation. Come back to another typical inflammatory disease and come back to the principle number 1 of low dose. Even if localized in a specific tissue, every disease is expression of the all P and EI axis, imbalance of the all EA axis. An example, osteoporosis. This is another interesting example, very paradigmatic example. I already asked you, which is the organ, tissue involved in osteoporosis? And you told me the bones. Yes, but no. Yes, because it's obvious. But look at osteoporosis as a systemic disease. Look at this slide, it's very nice. Female genital system, parathyroid, bones. Why we have a higher prevalence of osteoporosis during perimenopause and obviously in menopause? Because estrogens are lower. And why? Which is the connection between estrogens and the bones? He's in this slide, the connection is a systemic disease, osteoporosis. In fact, estrogens are able to talk to your skin cells, making them so beautiful, to your mammal gland, to your uterus, but they speak with all the cells in your body, including parathyroid gland cells. Estrogens, if you have, when you are not in menopause, homeostatic level of estrogens, are able to exert an inhibitory control on parathyroids. I mean, under the right quantity of estrogens, parathyroid produce the right quantity of parathyroid hormone. If you have a lack of estrogens, you don't have more this inhibitory control on parathyroid, and parathyroid says, hey, let's go party, and they produce an excess of PTH. I mean, PTH plus. And why PTH is so important in osteoporosis? Because PTH overexpress, alterate the homeostasis between phosphorus, calcium, and magnesium, increasing phosphorus and magnesium, provoking what? Acidosis. Do you remember that acidosis was one of the most important vital parameters? Because you need to keep your pH between 7 and 7.5. Instead, because of this mechanism, now the pH is lower. But you cannot live with the pH under 7. So immediately your body say, okay, I will fight against that. I need to neutralize those hydrogenions. What can I do? He has available only minerals for that. The first minerals, sodium, but you don't have so much. The second minerals, calcium. And where do you have the calcium? In the bones. So you take the calcium from the bones, and the bones, but that's not the real problem of osteoporosis. The real problem of osteoporosis is that this acidosis condition is the metabolic premise for the mother of every disease. Inflammation. Inflammation, by a metabolic point of view, is an acidic condition. In fact, your immune system, in a prevalent condition of acidosis, starts producing TNF-alpha and interleukin-6. Oh my God, the markers of chronic inflammation. These molecules are able to speak to every cells, including osteoclast and osteoblast. And TNF-alpha, interleukin-6 overexpressed, activate osteoclast, downregulate osteoblast. Which is the consequence? The bone. Exactly. What can we do according to conventional pharmacology for osteoporosis? Biphosphonate, alendronate, calcitonin, vitamin D, calcium. But if you don't treat by a systemic point of view osteoporosis, the results will be very relative. So now I involve you. According to this concept, for your patients with osteoporosis, what can you do? Where do you start? In this pathophysiological pathway that bring to the final results of the destruction of the bone. What do you do? Please.
To stop the interleukin-6 and
Yeah, this is good, but where everything started from? Low level of estrogens. Exactly. So what can we do? Okay, in low dose pharmacology, we have an interesting medication named Gunafem. It is a complex medication where you can find inside all the sarcoids, I mean the Swiss organ preparation, of all the glands of the endocrine network. Pineal gland, hypothalamus, hypophysis, and even more important, ovaries and corpus luteum. According to homotoxicology pharmacology, Reykjavik, those substances are able to stimulate the homologous target organ, stimulating the function. So, since it contains ovaries and corpus luteum, you can understand that estrogens and progesterone are produced more. This is a very interesting medication that always we think of not only in osteoporosis, but for instance in all the women in pre-menopause or in menopause. Very, very interesting, because you recover a percentage of capability to produce estrogens, avoiding all the problems related to a low estrogens level. Look, that is interesting to use Gunafem also in women who had hysterectomy and ovarectomy, because even though doesn't exist more the target ovaries or corpus luteum, you have glandula suprarenalis. Why it is important? Because adrenals produce steroids. Okay, so it's easy. Why? We use also in young women or girls with alteration in the menstrual cycle. It works like a pacemaker of the endocrine system. Okay, imagine Gunafem as a pacemaker of the endocrine system. Very interesting, speaking about experiences, is the association of Gunafem plus our serotoninergic natural medication that is named Gunamud. Gunamud. Especially in mood disorders related to estrogens alteration. Gunamud is really interesting because it contains tryptophan, 5-hydroxytryptophan, serotonin. It contains melatonin and, for my friends homeopaths, ignatia and lachesis muta, that in homeopathy is used to stabilize the neurovegetative tone, so to work against hot flashes, for instance. So it's very interesting in menopause, premenopause women, the association of Gunafem plus Gunamud. Okay, but come back to the osteoporosis. Good, we have been working on the first cause, where everything originated. Then we have the alteration of the parathyroid glands, which are producing too much of PTH. What can we do to take under control the parathyroid hormone? This is physiology, endocrinology. Which is the hormone able to induce the negative feedback on PTH? Calcitonin. Do you remember? Calcitonin makes sense, not because it fixes the calcium in the bones, but because it downregulates PTH. You understand? It's interesting. Where do we have calcitonin? In this medication named osteobios. It is a complex medication where you have calcitonin in physiological concentration and also parathyroid gland in the homeopathic dilution able to slow down the activity of parathyroid gland, but especially important is calcitonin. Well, Gunafem is increasing the estrogens. Osteobios through calcitonin is downregulating the PTH. Now we have to face the acidosis, because the results of this mess is the acidosis. What can we do for that? Baking soda? Okay. Why not? It's the best alkalizing. Neutralize, exactly. Or you can suggest your patient to eat 2.5 kilos of vegetables on fruit, fresh fruit. But it's very difficult to find someone doing that. Otherwise, you can intervene with some food supplements. I strongly recommend you this one. We work on for so long time. It is named Guna Basic. It is not an alkalizing product, but is a controller of pH. It is unique because it contains both citrate, carbonate, and phosphate. Since it contains these three different salts, we have been able to keep low the concentration of each salt. Many of alkalinizing products are made just with one salt, and they provoke kidney stones, for instance, because the big quantity. No, it is very well balanced. Besides the salts controlling the pH, Guna Basic is very interesting because it contains also some plants, and especially the bamboo fiber. Why, among the thousands of plants in the world, we thought of bamboo fiber? Exactly for that. Because in nature, bamboo is the plant with the highest concentration of silica. Which is the relationship between silica and the extracellular matrix? Is huge. Because I told you that the extracellular matrix is a connective tissue, where in the fundamental substance, beside 90% of water, you have 10% of proteins, which are proteoglycans and mucopolysaccharides. Proteoglycans are like necklace of amino acids, and these two chains of amino acids are kept together by a bridge of silica. If you don't provide the right quantity of silica, the proteoglycans, instead of to be in this way working as a good bioscaffold in the extracellular matrix, not having more silica, one goes on the left, one goes on the right, and you lose the good strength of the extracellular matrix. Providing bamboo, that means silica, you work on the histology of the extracellular matrix. Is the bone connective tissue? Absolutely, yes. So with Guna Basic, not only you control the pH, but also you feed the bones. You feed the extracellular matrix. I mean, you also feed the derma in the skin. But also, I told you, basic is important to counteract acidosis, which is the metabolic premise for inflammation, interleukin 6 and TNF alpha. I mean, Guna Basic is a very interesting anti-inflammatory product. So, if you combine matrix and interleukin 10, it's absolutely very interesting. When to provide to your patient Guna Basic? Normally we give 1 sachet solved in a glass of water once a day, every day for cycles of 2-3 months. It's better to give alkalinizing product in the morning or in the evening. In the evening, because, let me see if I have, no, I reproduce here, okay, because during the 24 hours, we have a trend of pH that is this one, look, in physiological condition. From 3 a.m. to 3 p.m., we have a prevalent acidosis. From 3 p.m. to 3 a.m., a prevalent alkalosis. Once again, the eternal alternance between yang and yin. Why Mother Nature? This is unbelievable. Eh? I mean, really, Mother Nature is perfect. Why Mother Nature decide to keep Fabrizio a little acidic, even Fabrizio, a little acidic for 12 hours every day? Because in our mind, acidosis is not good. Why? Because it's the metabolic premise for inflammation. So why, in other terms, for 12 hours every day, Mother Nature wants us to be inflamed? Because, my friends, to be a little inflamed, physiologically inflamed, in a controlled way inflamed, means to drain your body. Because if you are a little inflamed, you are burning toxins. So, how can I pacemaker control this mechanism? Through the alternance between acidosis and alkalosis. Another thing, because we are a little acidic in the morning, to have around 9 o'clock the physiological spike of cortisol, we need to be acidic. That spike of cortisol is physiological because it's in the morning that we have to be sympathicotonic oriented because we need to face the stress of this life. But we cannot stay 24 hours in this condition. Otherwise, please follow me, if you have a permanent acidosis condition, instead of to have this trend, you have this trend. I mean, instead of to be a little inflamed for 12 hours every day, necessary to burn toxins, to drain the overload of toxins in our body, we are inflamed for 24 hours. That's no good, because that's the picture of low-grade chronic inflammation. So, we need to counteract this possible attitude of our body because for instance, we eat a lot of meat, because we, all the triggers of acidosis. So, to reestablish the good and right pacemaker of pH, Guna Basic must be provided by night, because according to Mother Nature is the moment we have a prevalent alkalosis condition. If you give Guna Basic in the morning, you are counteracting what Mother Nature wants. Okay, it's important. I think that in the next 10 years, the chronobiology in the administration of the drugs will be much more studied than now. Now we know, for instance, about the use of alkalinizant. Okay, good. So Guna Basic is important, and then we have to counteract the overexpression of TNF alpha and interleukin 6, which are, as you know very well, the results of acidosis. And you know, I think that is already familiar with you, that the most powerful medication to take under control those two bastards is interleukin 10. And last but not least, you need to reestablish the right ratio between osteoclast and osteoblast. To do that, once again, we use osteobios that, beside calcitonin, contains the 3 homeopathic calcarea, some salts, able to feed the bone. So, this is the final protocol I suggest you for osteoporosis. Guna-Fem, Guna interleukin 10, matrix and basic, osteobios. This is really a very interesting protocol. We have a study, not control study, so it is not published on an indexed journal, but it shows with the densitometry the results using this protocol, and it is really very, very, very interesting. I know that is one of the problems that very commonly you observe, so I wanted to show to you our approach. Okay, good. Last part of our seminar. Can you resist other 30 minutes? Okay? Do you need cocaine? No. Are you? Yeah, but let's go to focus some little aspect on inflammation. You know what? I don't use the slides. Perfect. Last chapter of this seminar. What to do to keep under control inflammatory processes which are responsible of the 80% of the diseases. And I involve you to keep your attention. By an immunological point of view, inflammatory processes are expression of Th1 or Th2 overexpression. No question. Th1. Since Th1 are overexpressed, they produce too much of their interleukins. And especially, they produce too much of interleukin 1 and interleukin 6. Actually, they produce much more than these two interleukins. But in this moment, I want to focus your attention on these two ones. Why it is so important to remember interleukin 1 and interleukin 6? Because interleukin 1 is the trigger of acute inflammation. And interleukin 6 is the marker of low-grade chronic inflammation. So, according to the phase of the inflammation, first hours, first day, look that the acute phase of an inflammation lasts for no more than 2-3 days. We have to counteract interleukin 1 or interleukin 6. What can we do? According to low-dose medicine pharmacology, to counteract interleukin 1. The only possibility is to use a specific antibody. In fact, the half-life, you say half-life? Of interleukin 1 is very, very short. So you don't have the possibility to use an opposing cytokines telling some cells, please produce your anti-interleukin 1 interleukins. So we give an antibody that, excuse me, Bethany, come to me, so we have to show. Bethany is a inflamed cells, and disease, do this way, are transmembrane receptor. This is interleukin 1, trigger of acute inflammation, produced by Th1. Bethany, in this case, I don't know, is a cartilage cell. Interleukin 1 is traveling through the matrix to have the binding with the transmembrane receptor. After this binding, this cell will be inflamed. We use a monoclonal antibody, DNA recombinant, which is the activity of GUNA anti-interleukin 1. This is the interleukin 1, is going to have the binding with the transmembrane receptor, arrive the antibody, block it, and it doesn't allow the binding with the transmembrane receptors. So inside of this cell will not start the pro-inflammatory cascade mediated by NFKB and other cells. Thank you very much. This is the action mechanism of this medication in drops named GUN anti-interleukin 1. So, by a clinical point of view, we use GUN anti-interleukin 1 in the first 2-3 days from the onset of the inflammation. With this administration, 10 drops every 30 minutes for 2-3 hours until acute symptomatology disappears. After this shock therapy, in dentistry is very interesting to manage the pain and the inflammation, we pass for 2-3 days to the administration of 20 drops twice a day for 2-3 days. It works very well against pain, and it is a wonderful anti-fever medication. You can consider good anti-interleukin-1 as well as paracetamol. Acetaminophen. I don't know if you call paracetamol or acetaminophen. Okay? Good. This is the medication for the acute inflammatory process. Now, let's go understanding what to do to counteract interleukin-6. This is the picture of interleukins involved in all the inflammatory processes when you are facing a low-grade chronic inflammation. You can see that interleukin-6, instead of to go down as physiologically happen, remain up in the body of your patient. This is the picture of low-grade chronic inflammation. Look that every specialty you have, you are involved as doctors in facing everyday low-grade chronic inflammation because the cardiovascular system is affected by that. If you are a gastroenterologist, the gut is affected. IBDs, IBS, gluten sensitivity, celiac disease, but also depression, Alzheimer, autism, cancer, obesity, my God, the problem of obesity. If you look at a fat cell, it is a mine of leptin, interleukin-6, tumor necrosis factor. It's not an aesthetic problem. The problem is that you have a continuous, perpetual trigger of chronic inflammation. That's the reason why they die earlier. Epithelial tissues, we have seen vitiligo, psoriasis, male impotence, PCOS, polycystic ovary syndrome. You know that PCOS is very tightly related to insulin resistance. Insulin resistance is related to inflammation. So it's always that bastard interleukin-6 the cause of all this light. Osteoarthritis, osteoporosis, rheumatoid arthritis. I mean, if you will learn to use in all your patients matrix and interleukin-10, you will have immediately great results in all of them. Which are the cause of this epidemic of low-grade chronic inflammation now in 2017? The Western diet, first of all. GMO food that, thanks God, here in Europe is not like in America. Overweight and obesity. This is another big social sanitary problem. Remember, fat cells are deposit of interleukin-6. Chronic stress, we have seen that. Environmental pollutants, drug abuse, incorrect lifestyle, because we are always under stress. I always show this paper, very nice, for the new friends especially, published on brain behavior and immunity in 2013. What did they do? They relate the quantity of interleukin-6, marker of low-grade chronic inflammation, in the blood of subjects under negative emotions. What does it mean? They took some people and they provoke negative emotion in them, always increasing negative emotion, and then they took the blood, measuring, because it's easy, interleukin-6 in the blood. Two groups of people. One group of people from New York, super stressed. Okay? Another group of people from Japan, able to meditate. Look at the trend of interleukin-6 in Americans and in Japanese. That's amazing. Meditation, I'm not able to meditate, but maybe meditation work increasing interleukin-10. If you increase interleukin-10, you decrease interleukin-6. So, Fabrizio, Fabrizio is taking under control interleukin-6 through a good self-production of interleukin-10. because having this approach to life, this is the results, and it's not fancy, it's brain behavior and immunity. The problem is that many people, like me, are not able to meditate. Every time someone asks me to meditate, I ask her what I have to do. And she said, you have not to think. So I start thinking I don't have to think. And I think that I don't have to think, so I don't meditate. I always have this joke with Bethany, because Bethany is very good in meditation, not me. So, since Bethany doesn't need interleukin 10, I need interleukin 10 because I have not under good control my interleukin 6, and this is a real problem. So look that we are under attack of interleukin 6. All of you, all of your patients, we cannot not consider this aspect. I told you about inflammation, you remember? Okay, I go to this trend. Annals, New York Academy of Sciences, 2000. This is the trend of interleukin 6 during your life. Until 50, interleukin 6 is perfectly downregulated. After interleukin 6, after 50, unfortunately, it goes up. This is good because, okay, 110 years. The problem is that if you have some focuses of low-grade chronic inflammation, and we have those focuses, because of interleukin 6 very high, you move the trend of the curve towards the left, to the left. It means that instead of to die 110 years, we will die before, unless we will take guna interleukin 10. So it's interesting also in terms of inflammation. And the only medication able to work counteracting interleukin 6 now, in this moment, in the pharmaceutical panorama, I'm very proud because I dedicated almost my life to this, is guna interleukin 10. So please don't forget the use of this medication. Differently than guna anti-interleukin 1 for acute inflammation, guna interleukin 10 must be taken by the patient for a long time with the administration of 20 drops twice a day for cycles of therapy, 2-3 months yes, 2-3 months no, other 2-3 months yes, 4-6 months no, and in this way you will keep under control very well interleukin 6. And with these two medications, guna anti-interleukin 1 and guna interleukin 10, you will manage really very well inflammatory diseases. I finish my seminar showing you some two or three clinical trials published and published very, very well. And I start from the last published. Opla. Is still written in press. No more in press. I celebrate with you this ceremony. No more in press. Okay, published. Another kid, another pearl in my necklace. And this is a drug design, development, and therapy, impact factor 2.8. An open, randomized, active control clinical trial with low dose SKA, is our technique of production, cytokines, versus DMARDs. Disease, it means disease modifying rheumatoid arthritis drugs, exactly, evaluating low disease activity maintenance in patients with rheumatoid arthritis. I mean, we are speaking about rheumatoid arthritis, not common cold. Okay? I describe you the study design of this clinical trial that is really super interesting. Okay, like azacitidine. azathioprine, but also corticosteroids and so on. And they are very toxic.
Gold.
Exactly. So, what this group of rheumatologists did? They took patients with rheumatoid arthritis and they treated them with infliximab. Infliximab is a monoclonal antibody against TNF-alpha. According to the international guidelines, you cannot use infliximab, the biological drug, for more than 6-8 months because it is very, very toxic. And it works in an amazing way. In an amazing way. The problem is that as soon as you stop the administration of anti-TNF-alpha, the activity of the disease, I mean the inflammation, goes up again. So the rheumatologists are obliged to use DMARDs. So a group of patients after infliximab has been treated with DMARDs. Another group of patients after the same time, 6 to 8 months with infliximab, has been treated with a combination of low-dose Guna cytokines. Exactly anti-interleukin 1, interleukin 10, interleukin 4. You remember? Acute inflammation, chronic inflammation, autoimmunity. Perfect. 20 drops daily for 12 consecutive months. Don't be afraid, 12 consecutive months. We are speaking about rheumatoid arthritis. Okay? That is one of the most severe inflammatory diseases. So we compare the effect of DMARDs, gold standard therapy, with low-dose Guna cytokines. I forgot to tell you that DMARDs, they work very well. Just a little problem. Side effects. Just think to take for months and months and months corticosteroids. In fact, the compliance of the patients is very bad. They say, "Thank you, I don't want to take them." I have a friend of us with rheumatoid arthritis, and before entering in treatment, I hope because he doesn't want to take any medication with our protocol, he said, "Alessandro, I don't want to take any medication." But his name is Paolo. Paolo, but to understand, you are joined with me this way in 3 years. Eh? No, I don't want because I have side effects. I prefer to die, but not to live this way. Another time to say, how can help these people? Okay. Oh, sorry. I go straight to the results. Oh, okay. Please, look. I stay here. In blue, the group of patients treated with Guna. In red, with DMARDs. This is the so-called DAS28, Disease Activity Score. They measure the inflammation in 28 joints. Okay? And you can see that always the blue is a little, but just a little more effective than the DMARDs. CDAI, Clinical Disease Activity Index, is an algo-functional index, so the capability to walk, for instance. Better the treatment with Guna. This is the summation of this one and this one. Where is it? Okay. This is, oh my God. Okay. This is the pain visual analog scale. You can see that the Guna treatment is always better. I mean, with our medications, they felt less pain. This is quality of life index. And for those of you with the attitude to see the blood test, this is the ESR, erythrocyte sedimentation rate, more or less the same but a little better Guna treatment, and C-reactive protein, also in this case, a little better our treatment. This is, for me, this is something huge, because you will be in the position to keep low the activity of the disease. In the same way, we can say even better than DMARDs or corticosteroids. This is important because sometimes someone thinks, yes, but this low-dose medicine, okay, but it's not the same of a treatment with synthetic drugs. Okay, tell the editor of Drug Design and Development. I am in the position today to say that our treatment is the same, maybe even better than corticosteroids and DMARDs. If you needed to see results to understand the powerful of this low-dose pharmacology, this is an example. Another very interesting study performed by another rheumatologist named Matucci, Professor Matucci, who is head and chair of the Institute of Rheumatology at the University of Florence. He performed a study using a combination of anti-interleukin-1 and interleukin-10 in end osteoarthritis and low-dose anti-interleukin-1 in chronic gout. I go straight to the results because the pathogenesis is always the same. And you can see the trend of pain in orange, erosive end osteoarthritis, blue, no-dose osteoarthritis with Aberdeen nodes, and a little group of patients treated for knee osteoarthritis with a combination of Guna anti-interleukin-1 plus Guna interleukin-10, 20 drops each for 6 months. And you can see that they started more or less, all of them, and osteoarthritis, by from a 8 value in the pain scale. After 3 months, half of the pain, and after 6 months, almost nothing. This paper is in press. This is the protocol. And gout. Look that the prevalence of gout is quite important. 5 to 28 patients every 1,000 persons in male, and female 1 to 6. So you are more lucky than us.
What was the treatment with that?
For gout, only Guna anti-interleukin-1. In the paper, In the paper.
Oh, yeah.
Then, if you ask me, Alessandro, what is your approach? I tell you, Guna anti-interleukin-1, Guna matrix, and so on, okay? And these are the...
Treatment 10 as well?
no, in this case, no 10.
Okay, just the one.
Just Guna anti-interleukin-1. And please remember that the treatment for gout is colchicine plus allopurinol, and they are very toxic. In fact, for instance, using allopurinol, these are some side effects you can observe. Stevens-Johnson syndrome of the erythema multiforme. So, this is the trend of pain in patients after inserting in the treatment with colchicine and allopurinol Guna anti-interleukin-1. The trend of pain after 3 months and 6 months. until they were under treatment with allopurinol and colchicine, the pain didn't change. Inserting guna interleukin-1, immediately you had a big change in the trend of this of the pain of these patients. So really interesting. So if you will be able to manage guna anti-interleukin-1, just to summarize the big path we have taken together today: guna anti-interleukin-1, acute inflammation; interleukin-10, chronic inflammation; guna matrix, to clean the matrix; take care of the gut. I mean, you have a big bag of tools for the majorities of diseases of your patient. Then we have also seen through some papers just published, already published in press, the effectiveness of this new concept of pharmacology. Your question was so important because sometimes people ask me all over the world, Alessandro, which is the first reason why I would have to use this type of medication? You know, even more than the effectiveness, and you have the effectiveness in these papers, is the complete safety. Using this medication, never you will have a side effect. The only side effect you can have is a clinical side effect that using the wrong cytokine, you will not stop, for instance, interleukin-6, and the disease will have a progression. But in terms of pharmacology, 100% of safety. In each one of the 21 papers published, never a side effect. This is very important. Besides that, the efficacy, and the efficacy is really very strong. Okay, it is, look at the watch, it's 6:00. Thank you very much.